Hello and welcome to Digest This, where we focus on hot topics and day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastro trainee in the west of Scotland. Today the focus is on intestinal failure and nutritional support. I am delighted to welcome Dr Ruth McKee, a consultant surgeon here at Glasgow Royal Infirmary. Dr McKee is well placed to update us on this topic. She is the current Secretary of BAPIN and leads the nutrition team here at Glasgow Royal Infirmary. Dr McKee, thank you for taking the time to join us today. Perhaps to give us a bit of context, you could start off by explaining what you mean by intestinal failure.
But what it means is that you don't have enough functioning bowel to absorb sufficient nutrients and or fluids to keep you alive. And it is important to remember that that can apply just to fluids, or it can mean nutrients as well.
Now, you run the home parenteral nutrition service for Greater Glasgow and Clyde, and I know you have a collection of patients that you've looked after, some for a number of years. Can you tell us about a patient that you might see at clinic?
Yeah, well, we had a look at this before, didn't we? And one of the not untypical patients would be a girl who at the time this phone call took place was a student. And she had been taken to theatre in another hospital by a friend of mine who's one of the surgeons, and he was confronted with a difficult situation. A girl with very extensive Crohn's disease who had required emergency laparotomy because of an abscess that couldn't be drained radiologically. He'd managed to drain the abscess, but had found that she had an obstruction proximal to the abscess due to her extensive Crohn's disease, and felt that he really couldn't dissect out all the bowel and solve the problem completely. So he was really phoning for advice and asking whether it would be completely crazy just to bring out a very proximal loop stoma and try to get her better enough to have a more definitive operation. At that point in time, her BMI was something like 13, so she really wasn't well enough to have anything significant done. So this is really a damage limitation exercise. That's how it began. So he did that. Once the patient had recovered a bit, she came across to us here at the Royal, and she was a master's student at that point in time, picked up all the techniques remarkably quickly, and about 3 weeks after her transfer was discharged home on home parenteral nutrition. Completed her master's while on home TPN. About 9 months later, had further surgery when we were able to resect her active Crohn's disease at that stage. But because of our concerns about the safety of anastomosis, she had an even more proximal stoma performed as a loop above a total of 120 centimetres of small bowel and all of her colon. So she still, at that point, had a stoma at about 60 centimetres from the DJ flexure. So she was on home TPN at that point in time again.
And are there features that you would pick out from that history as putting the patient at risk of intestinal failure?
Well, of course, he's the kind of person that we probably all think of as being a person typical for home parenteral nutrition. Intelligent, young, extensive small bowel Crohn's disease. And if you look at our cohort of patients, that still is the most common reason for home parenteral nutrition, Crohn's disease. In fact, interestingly, when the Salford group looked at about 60 of their patients in the 1990s with Crohn's disease, it was interesting that about 65% of that group weren't on home parenteral nutrition because of the Crohn's disease itself, nor indeed because of multiple operations just gradually whittling away the bowel, but because they'd had surgery with complications and run into particularly septic complications. So the take-home message from that paper is that in a high-risk condition like Crohn's disease, really have to be very, very cautious about creating post-operative complications, because it's the complications that lead to short gut and need for home parenteral nutrition. Bit surprising, I think most of us think of the small bowel Crohn's patient.
So Crohn's disease would be the familiar situation for gastroenterologists, but you must see other causes of intestinal failure.
Yep, when we looked at our patients in recent times, Crohn's was indeed the most common reason for HPN. Next up reason was ischemia. More and more surgeons are resecting long lengths of small bowel in patients with acute ischemia and gangrenous small bowel, and of course that can leave people with very, very short lengths of bowel, and basically people are surviving now who would not have survived before. The other reason for home parenteral nutrition that's increasing, I think, unfortunately, is radiation enteritis. More and more patients are getting radiotherapy as treatment for not only cervical cancer, but prostate cancer and rectal cancer. And radiation enteritis can be very, very problematic and lead to short gut issues.
And when you first see a patient like the patient that you described, how do you assess whether they'll need enteral or parenteral nutrition? And do you have a sense of how things will go?
Well, obviously there is quite a lot that's to do with the anatomy. And I've bludgeoned enough trainees in recent years who've come through our unit in the west of Scotland that now most of the time the surgeon will measure the remaining length of small bowel. It's the bit that you've left behind that's important, it's not the length that you take away. So yes, remaining length is very important, and in fact in the early 90s Jeremy Nightingale, who's now at St Mark's, did some work looking at the lengths that were needed to sustain life without parenteral nutrition. If you have a small bowel stoma, then you need at least 100 centimetres of healthy small bowel. If you have all of your colon and a length of small bowel attached to that colon, then you may get by with 50 centimetres. But of course that bowel needs to be healthy. And the other interesting thing is that as the patients get older, if the renal function deteriorates, that can become an issue. If you have a high fluid loss and you're able to concentrate your urine efficiently, then you can manage to sustain yourself with reasonably high stoma losses. But if you're unable to concentrate your urine, you run into far more fluid balance problems more quickly. So the renal function comes into the ability to cope as well.
And can you give us a bit of a guide as to how the initial PN requirements would be calculated?
Well, the easy answer is that you find a dietitian and ask them. That's why we've got a multidisciplinary nutrition support team, and that's why every hospital should have one. And if that team includes doctors, dietitians, nutrition nurses and pharmacists. And the question for the dietitian is, what do you think the nutritional requirements are? And they're experts in using equations like Harris-Benedict, Ayrton-Jones, Henry, Schofield to calculate what they think the basal metabolic rate is. And they will then adjust that for activity and for stress and some extra perhaps for repletion of stores that have been lost. So they work out energy requirements and they'll also work out protein requirements. And then, of course, as doctors, we're used to dealing with fluid and electrolyte requirements depending on the weight and the clinical condition of the patient and their electrolyte values, with a bit of an idea of what kind of losses they might have. If they have a high output jejunostomy, clearly they're going to need replacement of fluid loss, they're going to need more sodium and more magnesium. So we can make an initial assessment, and then monitoring with fluid charts and weight and electrolyte measurements will help us to adjust that so that we have a more final calculation of their needs parenterally.
And what about the practicalities?
So the practicalities are that we would always put parenteral nutrition down a dedicated line. In this hospital in the Royal Infirmary, 2 of the consultant surgeons put in virtually all the feeding lines, and we tend to put in central venous lines. and have a good system for that happening fairly quickly. Some hospitals would put in PICC lines, peripherally inserted central lines, benefit that you're less liable to cause a pneumothorax because of how you insert them. Downside is that they can't really be used for feeding at home because you can't wash your hands and look after your own line if it's coming out of one of your arms. It's very awkward. So a dedicated central access, and for us that would mostly be single lumen Hickman lines for patients going home. A small number of patients would have a subcutaneous port. So that's inserted, and we're very strict about the protocols for use. Patients are really only given parenteral nutrition in a limited number of wards, mostly surgical and intensive care, where the nurses are very well versed in the protocols for changing the bags in an aseptic manner, and we have a low line infection rate. The feed is initially run over 24 hours. In patients who are going home, it's reduced to overnight. That enables them to be more active during the day, and they then have more chance of gaining muscle mass if they take a little bit of exercise, rather than just gaining fat once they're beginning to put on weight. And then once they're well enough, the nutrition nurse specialist would come along and train people to manage their own feeding if it's felt that they need home parenteral nutrition. That would usually take of the order of 3 or 4 weeks, and the patient would be trained to strict protocols to look after their own line, change their bags, do their dressings, and a whole lot of other information would be conveyed about management of complications and how they would deal with that. They would eventually go home with their feed and their supplies delivered by a home care company, and with contact numbers for our ward and our nurses and our team, so that if they do run into any problems, they have the ability to contact someone for help. They come back to our clinic within a month of their discharge, and then the review time is spread out depending on how they're getting on. People who are well and on long-term follow-up would usually be seen every 3 to 6 months, and we would check their bloods, their weight, their anthropometry, look for any potential complications, deal with any problems that arise. So we would try to be as supportive as we could for those patients, and we would also give them information about the patient support group called PINT that is active across the UK, and encourage them that if they were interested they could gain some support in that way.
Okay, so one of the main symptoms of intestinal failure is diarrhoea or high stoma output, which clearly can be measurable for the patient. What can we be doing to address this medically?
Quite a lot. Generally speaking, we would increase our treatment for a high output stoma gradually. At the very beginning, we would be asking ourselves whether there is some reversible surgical cause. So, for example, if they have intra-abdominal sepsis or a partial obstruction, that might be the cause of the high output stoma. And so we'd look for some physical cause like that. But assuming that that has been dealt with, then the first option would be to look at loperamide, taken regularly, starting at a kind of normal dose, 2 to 4 milligrams 4 times daily, but increasing up to 64 milligrams daily if necessary, if that reduces their output. We might add codeine phosphate if that's unsuccessful. It's got more central side effects, so we wouldn't use that as our first choice. We would add it to the loperamide. We would give them a PPI in high dose. And we would be careful with the formulation of these medications. So we, perhaps surprisingly, wouldn't often use syrups, partly because some of these syrups contain a lot of sorbitol, and that actually increases the output rather than decreases it. PPIs we'd often use fast tabs, or I think the official name is orodispersible. These are not absorbed in the mouth, but they dissolve in the mouth, and therefore we think that probably they are more effective for these patients. We don't have any actual proof of that. That's perhaps our next research project to look at that. And only if these relatively pain-free methods fail would we go on to asking the patient to drink things like double-strength Dowrolite, electrolyte mix, which has a concentration of at least 100 millimoles of sodium per litre. I don't know if you've ever tried one of these, but if you have ever tried one of these things, they're not very pleasant, and we tend to prescribe them, but I'm not sure that the patients that often actually drink them. So we'd only use those if the other things fail. We might think about using fluid allowance for patients. If patients have very short lengths of small bowel with a high output small bowel stoma, then they tend to have lost the absorptive part of their small bowel and been left with just a secretory part. And so if they take hypoosmolar fluids like water, then their proximal duodenum will simply secrete more water and more salt into the lumen, and their output will become higher. So we would discuss with them using a fluid allowance. I pick the words carefully. We used to call it fluid restriction. And then Caroline Wheatley, who's the chair of PINT, the patient support group, pointed out that really psychologically it was much better to use the term fluid allowance. And that usually works out of about a litre a day. Anything less than that is really very difficult for the patient to manage to keep up. So not taking too much hypotonic fluid. That, of course, only applies to those who've got intravenous fluids. If they're managing without intravenous fluids, if they're not quite bad enough for HPN, clearly they do need to have a higher fluid intake.
Let me take you back to the patient. It sounds as though initially they did well on HPN. How did they get on as you followed things up?
So this girl initially went home, I think, at about 38 kilos and with a BMI of 13. And 9 months later, with her master's degree, she came back and had a laparotomy, had her Crohn's disease resected. We did a loop ileostomy at 60 centimetres from the DJ flexure to protect an anastomosis further down. And so she remained on home parenteral nutrition with that high output stoma. Then we brought her back 3 months later and closed the stoma. And at that point she had 120 centimetres of small bowel joined to all of her colon. And as we might expect, her home parenteral nutrition requirements went from 4 litres a day, 7 nights a week, with that 60 centimetres of small bowel, to being 2 litres, 5 nights a week, immediately. Now, we would have expected that with 120 centimetres and all of her colon, she might have been able to come off HPN. So although she remains in general well and she virtually never complains, that's because she's got activity of her Crohn's disease, and her 120 centimetres is not healthy. And I think her fecal calprotectin is running about 1,000 at the moment, and she's on another medical treatment to try to control that a bit more, and she's not managed to come off her HPN, but she's holding down a full-time job. She's had one complication. She was in with a line infection. It was a Staphylococcus epidermidis line infection, and we treated it with antibiotics down the line. About 2/3 of patients with a staph epi line infection will be successfully treated with intravenous antibiotics down the line. But we still do that very cautiously. And if the bacteria is more aggressive, we would change the line and treat them with antibiotics or antimicrobials as appropriate. So, for example, if someone grows a yeast from their line, then we would, unless circumstances were completely exceptional, remove the line, and they would have a fortnight of antifungals and their line replaced at that time. I certainly have seen several patients where they've had candida uveitis and lost the sight of one eye because of yeast septicemias. So they would all get an eye review and they'd all get an echo. Patients with Staph aureus line infections can get SBE, and we've had someone in the last year who died of SBE because of a neglected line infection on their part. So the line infections need to be taken very seriously. This particular patient is very good, I think, at looking after her own line, but even people who are very good do get line infections.
And what about the issue of abnormal LFTs in somebody who's on parenteral nutrition?
Of course, there's an immediate assumption if anyone is on TPN and their LFTs become abnormal that it's the fault of the parenteral nutrition. So over the years, there's been the PNALD, so parenteral nutrition associated liver disease. And everyone tends to immediately jump to stop the fat in the TPN. There is a certain basis for that, but we'll get back to that. What we would be thinking of is that often people with abnormal LFTs have had more than one hit onto their liver. So some of them have, of course, in the west of Scotland, had alcohol excess in the past. More often, in our particular group of patients, it would be that they've had sepsis or have ongoing sepsis, whether it's intra-abdominal sepsis or line sepsis or something completely unrelated like a urinary tract infection. So make sure that all the sepsis is treated. Are they on any drugs? Fairly obvious. Do they have a completely unrelated liver disease? Do they have sclerosing cholangitis, for example? So if we've excluded all of that, then yes, we would look at the parenteral nutrition. With regard to the fat, there is some evidence that particularly in home parenteral nutrition patients, excess fat isn't good for you. Bernard Messing's group from Paris published a paper which showed quite nicely that patients who had more than 1 gram of fat per kilogram per day in their home parenteral nutrition were more likely to get cholestasis and significant liver disease. So we would think about the fat, and we would nowadays think about the type of fat. So we would tend to be careful with the old-fashioned intralipid omega-6 fat, and particularly in anyone with any concern about their liver function, we would consider using one of the newer fats with fish oils and omega-3s, which are less pro-inflammatory. Fat isn't the complete answer though, because if you take the fat out, you're going to have to give more carbohydrate to provide enough energy. And if you give lots and lots of carbohydrate, you might exceed the glucose oxidation rate of the liver, and you're then going to deposit fat in the liver from that source. So there's a question of, are we overfeeding? Are we giving too many calories in general? We do see quite a number of patients transferred from elsewhere where we feel there has maybe been some overfeeding and we reduce the amount of feed that they get. But it doesn't necessarily mean it's going to be fat-free. We do know that a particular group of patients are more at risk of getting abnormal LFTs, in that those with ultra-short gut are more likely to have problems. And if you think about it, their portal venous inflow is going to be significantly less because they've got such a short length of small bowel. So their liver blood flow in general is less. And we are very much more careful with them and with their prescription of PN than the average person.
Now, I imagine one of the things that you get asked a lot is, will I ever get off home parenteral nutrition? How do you deal with that question?
Well, obviously a lot does depend on the circumstances. There are some patients where we know that there may be a surgical way out for them, and we're hoping that with time this perhaps temporary high output stoma can be reversed in some way, and knowing about the gut anatomy and the possibility of reanastomosis of their bowel does help in terms of knowing, will they ever get off HPN. We've found over the years that about 25% of our patients will stop HPN. We looked at our patients over about 10 years just after 2000, and found that about a quarter of them got off. Mostly, I would have to say, because they had operations that rejoined bits of bowel. Only one patient, sadly, for the gastroenterologist, managed to get off HPN because of more effective medical treatment of her Crohn's. And she had to go back on subsequently when it failed. Not that surgery ever fails, of course.
And are there any other options for the patient like you've described beyond parenteral nutrition?
Yes, there are more options than there used to be. There's been development of a GLP-2 analogue, glucagon-like peptide analogue, which stimulates the growth of the small bowel mucosa and increases the absorptive capacity of the small bowel. And some studies based in Denmark mostly have established that that can reduce the amount of PN that patients need, about a 20% reduction. It's extremely expensive. So unfortunately at the moment the cost pretty much precludes its use in the UK, because it's not just a one-off cost, it's a lifelong prescription that the patient will need. And at this point in time, it's really much more expensive than home parenteral nutrition. But that's maybe an option that in the future more developments will come and we'll be able to use more adequately.
And what about surgical interventions?
Of course, I've already talked a bit about the fact that if we rejoin some of the areas of bowel that aren't being used, so for example, colon that's out of circuit, if you put the colon back into circuit, that makes a big difference to the fluid requirements and therefore their general stability, and can in fact improve the renal function quite significantly. So putting bits of both small and large bowel back in circuit is very useful. And of course the ultimate operation is to have a bowel transplant. And a number of patients will ask us, can't I just get a transplant for this? Well, intestinal transplantation is much better than it used to be. There are 2 adult UK centres, Oxford and Cambridge, and we do refer people for transplant. It's a formidable undertaking, particularly multivisceral transplant. Oxford at the moment does isolated small bowel, rather more straightforward. Cambridge does multivisceral and small bowel transplant. The assessment process is quite detailed, as you might expect, and we're very careful with the indications for intestinal transplantation. In general, the indications are complications of home parenteral nutrition, and the most common issues would be liver disease or loss of vascular access. And often there's great debate about whether the patient is suitable for a transplant or not. No one gets onto the UK transplant list for small bowel without being discussed at the UK National Forum, and then of course extensively assessed a bit at their home hospital and then usually at the transplant hospital for several weeks usually, because it's just such a significant undertaking. But results are improving, and there are a number of patients who've done very well from it.
Is there any role for intestinal lengthening?
The Salford group particularly are interested in intestinal lengthening, and in fact one of my colleagues, Phil Stevens, was their research fellow for a year as their intestinal lengthening fellow. Unfortunately, only a very small number of patients are suitable. You need to have dilated small bowel and you need to have colon in circuit. So out of all the patients that they looked at, the number of intestinal lengthening operations in adults that have been done is really still of the order of 2 or 3 in the UK in the last 5 years. So very tiny numbers at the present time.
And what is the long-term outcome for a patient like the one you've described on HPN?
Well, we have some figures because there used to be a managed clinical network for HPN in Scotland, and up to 2007 we reviewed our survival outcomes for Scotland. And these figures are probably unique throughout the world in that that's all comers in Scotland as opposed to a specialist hospital looking at very selected patients. And what we found was that the 1-year survival rate was 86%, 2 years 82%, and 5 years 77%. Survival mostly related to the underlying disease process rather than complications of home parenteral nutrition. So perhaps rather surprisingly, reasonable outcomes considering how unwell some of these patients are at the time. As you might expect, the very small number of patients who have HPN because of underlying malignancy are the ones who do least well. And then people with ischemia because of the associated cardiovascular disease. And fortunately, Crohn's disease tend to be the best risk patients on HPN.
Okay, finally, are there any key messages that you would have us take away from the discussion today?
Well, I've got a wee advert actually. Because I think that more people ought to be thinking about nutrition as a special interest in both gastroenterology and gastrointestinal surgery. I think we've already found when we've talked about some of the patients and some of the issues this afternoon that this is an extremely interesting and very varied area in gastroenterology and GI surgery, and it ranges from these home parenteral nutrition patients with all of their multiple complicated issues that interplay with one another to the issues of complex enteral nutrition where expert endoscopy intervention can really make a difference to the patient's quality of life. And of course in surgery, the whole area of intestinal failure surgery has become a much more acknowledged area of special interest in recent times. So for trainees out there, we think it's a good place to get into. And because Healthcare Improvement Scotland have recently published complex nutritional care standards, I think there probably will be a number of hospitals looking for people with an interest in nutrition over the next 5 to 10 years. So everyone should become interested in nutrition. If you want to be interested in nutrition, then joining BAPN, the British Association for Parenteral and Enteral Nutrition, is a useful thing to do. Lots of good information to be had. So come and join us. That's a take-home message.
Thank you, Dr McKee, for a fantastic and informative update on an important topic. And thank you for joining us for Digest This.